For the last video of this lecture, I'm going to explain some of the differences between study designs using a real-world pharmacy example, looking at the anticoagulant Lovenox in patients with morbid obesity. So this is an area of research that's been looked into a lot lately and kind of explains how a clinical question can be explained in various ways throughout the different types of study designs. So if we think of the hierarchy of evidence, expert opinion is down here at the bottom. Expert opinion should only be used if there is no other objective evidence to guide us in the literature. So expert opinion in the case of Lovenox and morbid obesity would be if you asked a clinical pharmacist how they would dose Lovenox in morbid obesity in the absence of evidence, and they might tell you, well, there's some pharmacokinetic differences, so maybe I would give the patient a little bit less than a normal weight dosing. So normal weight is 1 milligram per kilogram. Maybe they would say, well, I typically do 0.8 milligrams per kilogram. But we wouldn't really trust that judgment if we had more objective evidence. So that's expert opinion. We cannot make a causal argument whatsoever because it is simply an opinion of a person. One step up on the ladder would be a case report. Case report. So a case report would be, I have one patient, my population is n equals 1. One patient who is, say, 400 pounds. And let's say in the literature and the studies that brought Lovenox to market, the highest weight person was 300 pounds. So we're kind of in the dark here. We don't know how we should dose these patients. We don't know if 1 milligram per kilogram is safe. So say in this scenario, a patient presented to the hospital and the clinical team gave them 0.5 milligrams per kilogram and then drew a blood level called an anti-10A level was within normal limits, meaning that even though this patient got a lower dose, their blood plasma level was in the range that we thought it would be. And so the patient was discharged in good shape. So let's just say it was a good clinical outcome. But case reports are simply descriptive studies, right? So this is a descriptive study because there's no comparison group, and we just have one clinical outcome. And if we publish this, we might say that this could have publication bias. So a journal might publish this because it showed a good outcome. However, if we underdose the patient, a journal might not be that interested in publishing this. It just showed that you underdosed a patient, and then maybe the medical community doesn't get to see all the negative outcomes. So that's called publication bias. Case reports are subject to this bias, and they can't be used for causal assessments because they are can't show any of our three criteria of individual association, directionality, and experimentation. So let's move up the quality of evidence ladder some more. So expert opinion and case reports are below. Then we get to a cross-sectional. So cross-sectional studies are studies which look at exposures and outcomes at the same time. So we can't tell if one preceded the other, and that's a major drawback of these studies. But in this case, we could just simply do a survey and say, pharmacists across America, how do you dose Lovenox in morbidly obese patients? And maybe 75% say, well, I do the normal dosing. I do the dosing that's based on the studies, 1 milligram per kilogram. But the other 25% say, no, I do a lower dose, 0.8 milligrams per kilogram. And this would simply be descriptive. So there's no comparator group. We're just saying, how do people dose things? We're simply describing what happens in the pharmacy landscape in this situation. These studies can also be analytical. So you could look at additional variables here and say, which types of pharmacists are the more aggressive dosers? And you might say, of the high dosers, there are 75% of these are ICU pharmacists and 25% are other, as opposed to the lower dosers tend to be more other, 60%, and then 40% ICU. So you could start to do some analysis within here and get some individual level association. So of our three criteria, this analytical study fulfills the association We can make associations between variables, but no directionality and no experimentation. Okay, let's go one more step up the evidence ladder. So we had our initial case report said maybe lower dose Lovenox works because it was seen in one trial. So that generates a hypothesis in which we ask pharmacists across the country how they do it. And there's some mixed feelings there. So then we look into actual analytical research with a little bit higher quality of evidence. We do case control. But case control studies involve selecting a population of patients, say all the patients in Detroit hospitals, and then breaking them into two groups. And we want to know if normal weight dose Lovenox causes bleeding as opposed to lower dose Lovenox. So in our cases would be our outcomes. So we're grouping patients based on outcomes in case control studies. So our outcome would be bleeding on anticoagulation, morbidly obese patients who bleed on anticoagulation, versus morbidly obese patients who are on anticoagulation but do not bleed. And then we would look back at their exposures. And we would say, of the bleeding patients, 60% got 1 milligram per kilogram, whereas reduced dose was present in 40% of patients. Whereas those patients who did not bleed, it was reversed. Reduced dose was in a higher percentage. 1 milligram per kilogram was in 25%. And then so we have our incidence rates, and we can make a 2x2 table here. I won't do it here, but you can review slides from last week to kind of show how you could do an odds ratio in this case. So thinking of our causal criteria, 1, individual association, we do have. 2, directionality is sometimes difficult to prove in case control studies as well. And 3, experimentation is we do not have that one. So directionality means that we can tell clearly that the cause preceded the effect. However, since all case control studies are retrospective, we need to make sure that the Lovenox dosing occurred before the bleeding. Let's say we were just looking at bleeding patients and we accidentally selected patients who were bleeding before coming into the hospital, and then it stopped, and then we started the Lovenox. We might attribute a bleeding episode to the Lovenox when actually the bleeding came first and was in a prior, just happened before the Lovenox even was started. So in this case, usually we say that we can't fulfill directionality as well as we would like to in case control studies, although we can in really well-designed studies. But for the purposes of this discussion, we'll say that we're not fulfilling directionality, meaning cause preceding effect. Okay, so we have some indication that Lovenox may increase bleeding, but our study design is still not that optimal, so let's go above case control studies, and the next step up would be cohort studies. And we want to know, do bleeding rates differ in patients who have 1 milligram per kilogram dosing versus 0.75 milligram per kilogram dosing? So we selected our population, all patients in Detroit hospitals, but instead of grouping them based on outcomes, we grouped them based on exposures. So they were exposed to a higher dose, or they were exposed to a lower dose, and then we follow them forward. So we can be a little bit more certain about directionality here, because we're grouping based on the doses and then following them, seeing the outcomes that occurred after. So let's say bleeding was in, not 75, that's way too high, but in 13% of patients, and bleeding over here was in only 6%. So 87% did not bleed here, and no bleeding here occurred in 94%. So we have all our incidences here, and again, we can do a relative risk calculation very easily. But for now, we'll just look at the causal criteria. 1, individual level association. Yes, we have that. We can do a relative risk based on data collected from individual patients. Directionality, we can be a little bit more confident because we're grouping based on exposures and looking for outcomes that occurred afterwards, so we can be a little bit more confident here, especially if this was a prospective study. If this was prospective and we were just looking at patients who came into the hospital and were already being dosed this way or this way for whatever reasons and followed them forward, then we could be very sure about our directionality. But 3, experimentation is still not there. So our causal argument falls a little bit short. Why is this important? Because these patients may be dosed differently based on pre-existing clinical criteria. Maybe these patients were dosed more aggressively because they were more ill. They had more serious clinical presentations. Maybe these patients were dosed more with a lower regimen because they were old, or they had like chronic renal disease or liver disease or other reasons why you might be a little bit nervous about giving them a higher dose. And then so finally, we'll kind of get to the top of our chain of evidence for individual studies with an RCT, randomized control trial. So say that there's still some ambiguity and that there's multiple cohort studies and we're still not quite sure of the correct answer here, then we can perform our own study because there's still the clinical question. So for an RCT, we pick our population. Patients enter the hospital needing Lovenox to treat a blood clot. And then we randomly assign them 1-to-1 to be on normal weight dosing or reduced weight dosing. And then we say, what are the outcomes? Bleeding, no bleeding, bleeding, no bleeding, and we set up our 2x2 table, and then we can compute, again, relative risk. And in this case, finally, we have our association on the individual level. We have our directionality, cause precedes effect, and we know this because they don't even have the cause until we give it to them. And we have our experimentation. So experimentation is important because it ensures that there's a balance between groups in all the variables that are important to us. Ideally, the only variable that is significantly different between groups here would be the dosing of our anticoagulant that we're giving. So actually, this is a true story. All of these studies are currently out there for enoxaparin, and the data is so mixed with lower quality studies that this study is currently underway in Atlanta. So this kind of wraps up how study designs can be used in different ways and the criteria that we can infer from them when making causal assessments. Please let me know if you have any questions about this. Thank you very much.